Welcome to the deep dive. Treating a life-threatening illness like breast cancer, it's a lot like putting out a massive house fire.
Yeah, that's a really good way to look at it.
Right. I mean, the immediate, absolute priority is survival. You bring in the heavy hoses, you douse the flames, you break the windows, you just do whatever it takes to save the structure. And, it works. The fire's out.
Right.
But
Yeah.
once the smoke clears and the adrenaline fades, you are left living in a house that, while saved from the flames, is now dealing with devastating structural water damage.
Exactly. We celebrate the extinguished fire, as we absolutely should, but the medical world has historically, kind of failed to prepare the patient for what it actually means to live in the aftermath of that flood.
Right.
Because the structural damage left behind, it can completely alter how a person navigates their daily life.
And that structural damage is really the mission of today's deep dive. We are looking at a stack of clinical guidelines from the British Menopause Society to the American Society of Clinical Oncology.
Yeah, plus some really fascinating recent clinical trial data and specific oncology case studies.
Exactly. We're unpacking one of the most hidden, unspoken side effects of breast cancer survival, which is severe vaginal dryness and a condition medically termed the genitourinary syndrome of menopause, or GSM.
Yeah, GSM. And it is a side effect that dramatically alters a person's quality of life, yet it just remains shrouded in silence. So today, we're going to break down exactly why life-saving cancer treatments cause such intense physical changes to the pelvic region.
And why patients really shouldn't have to suffer without help.
Right. We will dive into the fascinating, almost paradoxical science of how doctors are learning to treat this damage without risking a recurrence of the cancer.
So, whether you are a breast cancer survivor yourself, or maybe you're supporting someone who is, or if you're just someone who wants to understand how incredibly interconnected our body's hormonal systems really are, this deep dive is for you. Because this is about learning how to fiercely advocate for your own quality of life. Surviving is the first step, but actually living is the goal. But okay, let's unpack this. Before we can even talk about fixing the problem, we need to understand exactly what these breast cancer treatments are doing to the body's cellular environment.
Right. The mechanism.
Yeah, like how do we get from treating the breast to devastating the pelvic tissue?
Well, to understand the damage, we really have to look at the mechanism of the cure. For, I'd say, roughly 75% of breast cancer patients, their cancer is estrogen sensitive.
Meaning the cancer uses estrogen to grow.
Exactly. The cancer cells use the hormone estrogen as fuel to multiply. So a massive pillar of breast cancer treatment, whether that involves chemotherapy, ovarian suppression, or long-term endocrine pills, it's all designed to deliberately starve the body of estrogen.
You're just completely cutting off the fuel supply so the cancer can't grow.
That's the goal. But,
Right.
Estrogen isn't just fuel for cancer. In a healthy body, it is a vital structural component.
Right, for other organs.
Yeah, particularly for the female reproductive and urinary systems. Estrogen is essentially the architect that keeps the tissues of the vagina, the urethra, and the bladder thick, elastic, and well supplied with blood flow. It maintains the collagen.
Wow, okay.
So when you medically eradicate that estrogen, you trigger what we call iatrogenic menopause, which is just the medical term for menopause induced by treatment rather than natural aging.
Right, and from what I'm seeing in these clinical guidelines, iatrogenic menopause is not just your standard natural transition. It seems, much more aggressive.
Oh, it is entirely different in its intensity. Natural menopause happens gradually over several years. It allows the body's tissues time to kind of adjust to the declining
Nice.
hormones.
Like a slow fade.
Exactly. But iatrogenic menopause is an abrupt, sudden plummet. To give you a stark comparison from the clinical data, in a natural menopause, a woman's testosterone levels, which alongside estrogen are crucial for pelvic tissue health, they sit around 290 picograms per milliliter.
Okay, 290.
But in iatrogenic menopause caused by these cancer treatments, those levels drop to just 110 picograms per milliliter.
Wait, down to 110.
Yeah, it's a huge drop.
So if we think about the body's baseline as a car running on a full tank of gas at 290, these treatments drop the tank down to 110. You're basically forcing the body to run on fumes overnight.
That's exactly it. The drop is staggering. And it's not just testosterone. If you look at a patient's lab chart, you'll see a whole alphabet soup of hormones. Estradiol, androstenedione, DHEA.
And all of those are affected.
All of them. Think of these as the different tools and building blocks the body uses to maintain tissue integrity. The cancer treatments drive all of them to subphysiologic levels, meaning much lower than what the human body would ever naturally reach on its own.
Wow.
This creates an absolute estrogen desert in the pelvic region. Without those hormones, the tissues of the vagina and urinary tract literally thin out. They lose their collagen, they lose their elasticity, and the blood flow just drops to a trickle.
It makes me think of like a kitchen sponge. If you have a wet, hydrated sponge by the sink, it's flexible, it's bouncy, it can take a lot of pressure and friction without tearing.
Yes, exactly.
But if you take that same sponge and leave it out in the hot sun for 3 days, it becomes an entirely different object. It shrinks, it loses its physical structure, and if you try to bend it, it doesn't flex. It just cracks and breaks.
That's a perfect analogy. And taking that sponge analogy a step further, unlike a kitchen sponge, you can't just run this human tissue under the tap to fix it. Those cracks in the cellular tissue translate to severe chronic pain.
And that's the GSM we mentioned earlier.
Right, genitourinary syndrome of menopause. This isn't just a bit of uncomfortable dryness. I mean, it manifests as severe pain during sexual intimacy, intense itching, and irritation that makes just walking, exercising, or even sitting in a chair unbearable.
Sitting in a chair, that's debilitating.
It really is. It also leads to a high susceptibility to recurrent urinary tract infections. Because the tissue is so compromised, bacteria can easily invade, and that can sometimes escalate to urosepsis, which is a life-threatening systemic infection that starts in the urinary tract.
There's a specific case study in our stack of sources from the Cleveland Clinic that really highlights how terrifying this physical reality can be for a survivor.
Oh, the 46-year-old patient.
Yeah, she came into the specialty clinic presenting with vaginal bleeding.
This case is incredibly revealing, especially about the psychological toll of GSM. She had previously been treated for early-stage breast cancer, and her treatment included a hysterectomy, the removal of her ovaries, and a long-term prescription for aromatase inhibitors.
Which are the drugs designed to wipe out estrogen production.
Right.
And obviously, if you are a cancer survivor on a drug meant to keep you in remission and you suddenly start bleeding, your mind immediately goes to the darkest possible place. She was absolutely terrified her cancer had returned.
You can totally imagine the panic in the waiting room. But when the doctors examined her, they found the bleeding wasn't a cancer recurrence at all. It was a urethral caruncle.
A urethral caruncle, what exactly is that?
It's a large red mass on the urethra caused entirely by severe hormonal deficiency. Her tissues were so starved of estrogen, so completely devoid of that structural architect we talked about, that they had become what doctors call friable.
Friable?
Yeah, it means the tissue is so brittle and fragile it essentially crumbles and bleeds like wet tissue paper at the slightest friction. The doctors actually had to treat it by temporarily pausing her cancer drug and giving her a short, localized course of topical estrogen just to heal the broken tissue.
Okay, if the symptoms are this severe, if their tissues are essentially turning to glass, mimicking cancer recurrences, causing bleeding just from moving around, oncologists can't just tell them to deal with it. Why aren't doctors warning patients that this is an expected side effect of the fire hose?
It's tragic, honestly. These symptoms are vastly underreported by patients, often out of embarrassment or this deeply ingrained belief that they just have to suffer as the price of surviving cancer.
Still cost of admission.
Exactly. And historically, oncologists have been so hyper-focused on keeping the cancer away that they haven't always proactively asked about sexual or vaginal health during follow-ups. And the consequences of this communication gap are staggering.
How so?
Well, the data shows that up to 30% of breast cancer patients actually stop taking their life-saving endocrine therapies within 2 years.
Wait, 30%. 30% of people are essentially choosing the risk of a fatal cancer returning over the daily reality of this pelvic pain.
Yes.
They're abandoning the drugs, keeping them in remission. That is unbelievable.
It highlights a massive failure in survivorship care. Survivorship has to be about more than just a lack of disease. It has to be about preserving the person's life.
Wow. So we understand the severity of the tissue damage, the dried out sponge running on fumes. How do we heal it without flooding the body with the systemic estrogen that could feed a dormant breast cancer cell? According to the British Menopause Society and other guidelines, the first line of defense is strictly non-hormonal.
Right. Medical guidelines universally mandate that non-hormonal treatments must be the first step. And here, we really have to make a vital clinical distinction between lubricants and moisturizers.
Okay, because people mix those up all the time.
They are frequently confused, yes. but they serve entirely different biological purposes.
My understanding is that a lubricant is basically like spraying WD-40 on a rusty, squeaky door hinge. It gives you a quick fix. It stops the friction for the 10 minutes you need it to, but it doesn't actually do anything to treat the underlying rust on the metal.
That is a brilliant way to put it. Lubricants, which by the way should be water-based or silicone-based, completely avoiding oil-based products like Vaseline.
Right, because Vaseline degrades tissue.
Exactly, it degrades tissue and traps bacteria. But lubricants are used purely to reduce friction during intimacy. They provide short-term, superficial relief. A vaginal moisturizer, on the other hand, is a completely different medical intervention.
It's the rust treatment.
Yes. To build on your door hinge analogy, a moisturizer is the equivalent of sandblasting the metal, applying a rust remover, and retreating the structure. It is an active therapy meant to change the cellular environment.
But how does that actually work on a cellular level without hormones?
Let's look at hyaluronic acid treatments or polycarboxyl-based gels like Replens. These products actually bind to the vaginal epithelium, which are the very surface cells of the tissue.
Okay, they bind to the surface.
Right. And hyaluronic acid is incredible at holding onto water molecules. So by binding to the surface, it physically pulls water and essential electrolytes deep into the underlying cells, forcing the tissue to replump itself.
Oh, wow. So it's actively hydrating from within.
Exactly. And by restoring this moisture, they also lower the vaginal pH back to a healthy acidic level, which creates a hostile environment for the bacteria that cause those severe urinary tract infections.
That makes sense.
But the crucial clinical point here is consistency. They have to be used 2 to 3 times a week, every single week, completely independent of sexual activity, to maintain that cellular hydration.
Hold on. Let me stop you there for a second. Are we just masking the pain by keeping things wet, or do these moisturizers actually reverse the physical damage to the tissue?
No, the clinical trials show real structural healing. When used regularly for 8 to 12 weeks, moisturizers genuinely improve the morphology of the epithelial cells.
Really? Like under a microscope?
Yeah, if you take a vaginal swab from a patient using these properly and look at it under a microscope, the cells actually look healthier, more robust, and more mature. They regain some elasticity, and it drastically reduces the chronic itching.
That's amazing for a non-hormonal option.
It is. However, we have to acknowledge a hard biological ceiling here. They do not replace the missing estrogen. Because the root cause of the atrophy is a lack of hormones, non-hormonal moisturizers eventually fall short for the most severe cases.
This means eventually those patients are going to need hormones.
Yeah.
But giving estrogen to a survivor of estrogen-sensitive breast cancer, I mean, that sounds like walking through a medical minefield.
It absolutely is a minefield. To safely navigate it, oncologists and menopause specialists have to look at the exact type of endocrine therapy the patient is taking to keep their cancer away. The biology changes depending on the drug.
Okay, here's where it gets really interesting, because there are 2 main categories here, right? Aromatase inhibitors, or AIs, and tamoxifen.
Right.
Let's break those down, starting with the AIs. The sources mention drugs like letrozole or antrazole.
Right. So aromatase is an enzyme in the body's fat tissue that converts androgens into estrogen. This is actually how postmenopausal women produce estrogen once their ovaries stop.
Okay, through the fat tissue.
Yeah. Aromatase inhibitors work by blocking that enzyme completely. They wipe out all systemic estrogen in the body. So for a patient on an AI, introducing even an ultra-low-dose vaginal estrogen is highly controversial in the oncology community.
Wait, I think I see the danger here. If AIs work by creating a zero estrogen environment, putting an estrogen cream directly onto the fragile bleeding tissue sounds like dropping a match in a powder keg. If even a microscopic amount of that estrogen gets absorbed through the vaginal wall and into the bloodstream, couldn't it wake up dormant cancer cells?
That is the exact theoretical fear that keeps oncologists up at night. The concern is that any systemic absorption could completely negate the cancer-fighting effects of the AI.
Wow, so what do they do?
Well, some guidelines say it's completely contraindicated, meaning just do not do it under any circumstances, while others say it should only be a last resort after extensive documented counseling.
If you're listening to this and you're taking an astrazole or letrozole, you might be feeling a little panicked right now hearing that you can't safely use local estrogen. But stick with us, because the alternative pathways here are actually incredible. And that brings us to the second drug category, which is tamoxifen.
What's fascinating here is how tamoxifen works. It is what we call a selective estrogen receptor modulator, or a SERM. Unlike AIs, It doesn't eliminate estrogen from the bloodstream. Instead, it works at the receptor level.
Okay, how does that work?
Think of an estrogen receptor like a lock on a door on the outside of a cell. Tamoxifen acts as a fake key. It sits in the estrogen receptors of the breast tissue, jamming the lock so the real estrogen can't get in to fuel the cancer.
Ah, so in the breast, it is an antagonist, a blocker.
Exactly.
But it doesn't jam the lock everywhere in the body. Why is that?
Because the locks are different depending on what room of the house you're trying to enter. Receptors in different tissues have different co-regulators.
Oh, that's clever.
Yeah, so the tamoxifen key jams the lock shut in the breast tissue, but when that same drug reaches the uterus and the vagina, it actually turns the lock and opens the door. In the pelvic region, tamoxifen acts as an estrogen agonist, meaning it mimicked the effects of estrogen.
Wait. A drug prescribed specifically to start breast cancer actually acts like hormone replacement therapy for the pelvic region.
Yes. It is a phenomenal twist of biology. This is why women taking tamoxifen often experience vaginal discharge rather than dryness, because the drug is actively stimulating and thickening the vaginal tissues.
That is wild.
And this biological quirk leads to a radical guideline-approved pivot in patient care. If a woman is on an aromatase inhibitor, suffering from severe, agonizing vaginal atrophy that doesn't respond to moisturizers and is at risk of abandoning her treatment.
Her oncologist might suggest simply switching her cancer drug from the AI over to tamoxifen.
Exactly. Just making that switch could heal the vagina all on its own, utilizing tamoxifen's mimicking effect in the pelvis.
That is just brilliant.
Or, even if she still requires a localized estrogen cream to heal severe tissue damage, it makes it much safer to prescribe. Because if any of that vaginal estrogen absorbs into her bloodstream, the tamoxifen is already standing guard at the breast tissue, jamming the locks.
This highlights why survivorship care requires such highly coordinated communication between a patient's oncology team and a menopause specialist. You simply cannot treat the breast and ignore the pelvis.
You really can't.
So if swallowing a tamoxifen pill has these estrogen-like healing effects on the vagina, what happens if we skip the digestive system entirely? Like, what if we bypass the bloodstream and put the drug directly where it is desperately needed?
We are actually starting to see the answers to that in a very recent, fascinating proof-of-concept clinical trial out of Sweden.
Oh, let's get into this.
So researchers took 115 postmenopausal women suffering from moderate to severe vaginal atrophy, and this included breast cancer survivors, and they tested a vaginal tamoxifen treatment.
A vaginal tamoxifen treatment.
Yes. They used a 20-milligram dose administered directly into the vagina just once a week.
And the results from this trial are staggering. After 3 months of this weekly treatment, nearly 69% of the women on the vaginal tamoxifen reported that their most troublesome symptom was either mild or completely gone.
Exactly.
Compare that to the placebo group, where only about 9% saw that kind of relief.
And the physical measurable changes were just as impressive as the symptom relief. The clinical exam showed that the vaginal pH lowered back to healthy, infection-fighting acidic levels.
Wow.
And crucially for safety, it did this without dangerously thickening the endometrial lining of the uterus, which is a known serious risk when taking oral tamoxifen pills.
How does putting it in the vagina prevent it from affecting the uterus right next door?
It's all about blood flow.
The researchers theorize that's because of something called countercurrent transfer, right?
Yes, exactly.
Yeah. Basically, the anatomy of the blood vessels supplying the urethra and vagina means the drug gets absorbed and circulated locally in that specific tissue network, rather than traveling up the reproductive tract to the uterus.
That's the current theory, yeah.
But, okay, I have to ask about the reality of applying this. We know tamoxifen is a harsh drug. If you are putting a chemical directly into vaginal tissue that is already damaged, thin, and highly sensitive, doesn't it cause intense local irritation?
Yeah, that is a very real side effect. A significant number of women in the tamoxifen group did experience initial burning, discomfort, and increased discharge, especially in that first month of application.
Ouch.
Yeah, the delivery method used in the trial was just a standard tablet, which isn't perfectly formulated for delicate tissue yet. But for the vast majority of these women, the deep cellular healing they experienced by month 3 made that initial irritation entirely worth it.
It proves the biological concept works.
Right, we just need pharmacology to catch up and refine the delivery system into a soothing cream or gel.
And tamoxifen isn't the only localized frontier being explored. The clinical guidelines also detail the use of DHEA, specifically a prescription insert called prasterone or Intrarosa.
Yeah, DHEA is a precursor hormone. And what makes a vaginal DHEA insert so incredibly unique is that it doesn't actually contain active estrogen.
Okay, so what does it do?
It delivers DHEA directly to the vaginal surface, and those specific cells absorb it and convert it into estrogen and testosterone entirely intracellularly.
Meaning the conversion happens strictly inside the cell itself.
Exactly.
So imagine a factory with no shipping doors. The cell takes in the raw material, builds the estrogen it needs to survive, but it can't ship that estrogen out into the rest of the body.
Right.
It becomes a closed-loop system, keeping the hormone production strictly local.
Because the conversion happens inside the cells, clinical blood tests have shown it significantly improves vaginal health, rebuilds the collagen, and stops the pain completely without raising estrogen levels in the systemic bloodstream.
That sounds like a game changer.
It is. Now, if you read the guidelines, you will find some conflicting advice. Some older medical guidelines list DHEA as contraindicated for breast cancer survivors out of an abundance of caution, just assuming any hormone will leak into the blood.
Sure, playing it safe.
But newer data and several updated oncology guidelines suggest it is a safe and highly effective option, even for women on aromatase inhibitors, precisely because blood tests confirm that lack of systemic absorption.
As always, this is something a patient must discuss directly with a coordinated care team. You have to weigh the specific characteristics of your tumor against the severity of your daily symptoms.
Shared decision-making is the bedrock of modern survivorship care. The patient simply has to be in the driver's seat.
Absolutely. Well, we started this deep dive looking at the harsh, hidden landscape of iatrogenic menopause. We look at how cancer treatments, by design, starve the body of estrogen, turning resilient tissue into a brittle, fragile environment.
We explored the vital difference between just lubricating for temporary friction and actively moisturizing to rebuild cellular structure.
We navigated the incredible paradox of tamoxifen, a drug that fights cancer in the breast while acting as a structural hormone replacement in the pelvis.
And we saw how oncologists are leveraging that biological quirk to safely treat patients who otherwise felt they had to choose between their cancer drugs and their sanity.
So what does this all mean? The ultimate takeaway here is about the true definition of survivorship. Surviving a disease isn't just about eradicating the cancer cells. It is about preserving your quality of life in the aftermath.
It's about actually living.
Exactly. If you are listening to this and dealing with these symptoms, or if you know someone who is, you need to know that you do not have to choose between staying alive and feeling whole. But it absolutely requires active, informed self-advocacy. You have to tell your doctor about the water damage in the house.
You really do. And the clinical trials on vaginal tamoxifen and localized DHEA, they raise an incredibly important question for the future of medicine. We are entering an era of highly targeted therapy where the physical location of the drug matters just as much as the chemical compound.
Think about the implications of changing the delivery zip code of a drug. If we can take a systemic breast cancer drug like tamoxifen, stop having patients swallow it, and instead apply it locally to cure the very side effects caused by other breast cancer drugs.
What else is possible?
Right.
Exactly. What else is possible?
It forces the medical community to rethink how we administer medicine across the board. Like, what other systemic side effects in oncology, autoimmune diseases, or really any other field could be solved simply by placing the medication exactly where the body needs it and nowhere else? Could the poison truly be the cure if we just learn exactly where to put it?
It changes the whole paradigm. You don't always need to flood the entire house just to put out a fire in the kitchen. Sometimes you just need to know exactly where to aim the extinguisher. Until next time, keep diving deep.